trying to round up?
Oh, by symbolically.
Let's see.
So, 15 minutes per talk.
10 plus 5.
So,
10 minutes plus 5 minutes for questions. So use 15 minutes assigned for that. It's kind of.
so we have a little bit of time. Do you want to move into, like, you can't really do that.
I think what will happen, we always run into challenges with time. So I think we'll just be okay. And if we have a little bit of extra time, maybe we'll post or some people in transition. So
Could everyone please come into the auditorium and take your seats? We're going to get going now. It's fabulous to hear all the buzz and see everybody getting together, enjoying each other's company. I want to officially welcome you to this year's Gallie Day. Gallie Day is a huge event for us here in the Department of Surgery at the University of Toronto. It's a day of science and celebration. And it's a very important day for us to recognize the contributions, the excellent work being done by all of our colleagues and learners across the Department of Surgery, across our 8 clinical divisions. So that is, I'm not going to do a quiz, but that is cardiac, vascular, thoracic, orthopedic, general, urology, neurosurgery, plastic reconstructive and aesthetic surgery, plus our division of anatomy. So that gives you an idea of the breadth of this department. It's huge. And you're going to hear a lot of excellent science today. In addition to welcoming all of you, want to welcome our visiting professor, who is Ram Nataraja, who's visiting us from Monash University in Melbourne, so very long trip. He's already met with many of you, and it's fantastic to have him here. He's going to be introduced shortly by Michael Failings. So as more of you gather and settle in, I want to begin by acknowledging that the land upon which we are meeting, the land upon which the University of Toronto operates, was for thousands of years the traditional homeland of many Indigenous peoples, including the Haudenosaunee, the Huron-Wendat, the Mississaugas of the Credit, and the Anishinaabeg. Today it continues to be the homeland of many Indigenous peoples, and we wish to recognize the historic injustice done to them and seek to do better in our relationship with them and with this land, which it is our duty to steward. So next, just to touch briefly on the topic at hand, this has been our scientific theme for the year, and you're going to hear more about this from Dr. Failings. The role of simulation, robotics, and education, and the synergy between these 3 topics is what we're focusing on today in our symposium and our visiting speaker choice. And you're going to hear a lot of discussion about this throughout the day. And then at our simulation summit on May 14th, which some of you have been invited to and graciously accepted our invitation. So I want to also thank the people who have made today possible. It's as I said, it's a huge department, it's a huge effort, And I want to recognize Dr. Failings, our Vice Chair of Research, as well as the Research Committee members, and also, in particular, Josef Ellenbogen and Asha Bedinan, the SSTP residents, who've worked so hard to put this program together and organize everything. And finally, and most importantly, our stalwart staff member, Renato Musa, who makes the research committee function and has made today it's the great day that it's going to be. So in conclusion, welcome to all of you. I'm so happy you're here. Thank you.
Well, welcome to our 2026 Gallie Day, and indeed it is it's a day of science and celebration. I think that was very eloquently put. I think most people know me. I'm Michael Failings, Vice Chair for Research in the Department of Surgery, and for me this day is always one of great joy. And we're seeing remarkable innovations and very positive, and challenging disruptions that are occurring in our professional lives. Last year we were talking about the impact of artificial intelligence and machine learning, and we're now seeing, the evolution of differing technologies that I think will enhance what we do as surgeons and as teachers, but will also represent challenges for us going forward. And robotics and simulation embrace different elements. There are technical elements to this, of course, and then there's differing ways in which we might wish to use this to teach skills and then also to evaluate skills. And will these technologies replace surgeons? I really doubt that. I think there are a lot of elements of what we do that just frankly, cannot be replaced by a machine. There are certain human elements, but I envision that these technologies will certainly have an impact in terms of what we do, and this is what we're here to explore today. So, as we celebrate the future, it's also important to acknowledge, the past, and some people will know who this is, and some people will have no idea who William Gallie is. But William Gallie, for whom Gallie Day is named after, and in fact, many of my teachers have referred to our training program as the Gallie program, and the reason for this is that William Gallie was a pioneer in the development of an organized approach to the teaching of surgical specialists, and was one of the pioneers in America. Halstead was a significant pioneer, and William Gallie, I believe, established the first organized residency training program in surgery here at the University of Toronto, and it is with his legacy that our program has evolved. But here we are to talk about the present and the future, defining the future of surgery. Where will surgical simulation or robotic technologies lead us? And we're very honored to welcome Professor Ram Nataraja, who has traveled across the pond with us from Australia, and he's been here for a couple of days, very kindly lending his tremendous expertise and collaborative spirit with us, and we'll be looking forward to his keynote Gordon Murray lecture later on driving change, the impact of low-cost simulation-based educational innovations in resource-limited settings. And I'm really looking forward to this talk. I think this will really embrace many of the concepts that we're hoping to discuss today. So, I'm really blessed to work with a fantastic a group of people. And we have a very vibrant research committee, and I won't list all of the names here, but I will, point out a few people. One is my Associate Vice Chair, Andras Kapus, and Andras represents the faculty in the department who have primarily a research focus, and there's a substantial number of faculty, and they're very valued, and so that's a very important role. And Professor Swallow has made a reference to Renata Musa, who is our research program coordinator and who is fantastic, and she's had a huge role with the organization of today. And I also want to recognize Asha and Joseph, who are our two surgeon scientist trainee representatives on the research committee, and we have a broad representation from all of the divisions on our research committee. We have a very active surgeon scientist training program, and Ram, we were discussing this a little bit, last evening, but our program has really pioneered the concept of an organized period where surgeon scientist trainees have the opportunity, if they wish, to do a graduate-based research training at either the master's or the PhD level with departmental and divisional support, and this is our current cadre of surgeon scientist trainees. And this will give you an idea of the number of trainees that have gone through our program. It's varied a little bit from year to year, but it's around 40 each year, plus minus. And this just shows a breakdown of those undertaking thesis-based master's degrees or PhDs, and you'll see there's a representation from all of the divisions in our surgical department. We have a very vibrant research network in Toronto, and this is reflected by a very impressive success at the grant level, and this number is starting to approach 200 million a year, which is, I think, quite an impressive number, particularly given the current challenging grant funding environment. And the publications are also a marker for the strength of the Department of Surgery, which is ranked among the top 3 in the world, and it's not just the number of the publications, but it's the impact of these publications, which is quite substantial. But that in and of itself is a very impressive number, and certainly the Department of Surgery is a big driver in the international reputation of the Faculty of Medicine, frankly, of the University of Toronto. So lots of people to thank in terms of the organization. So I've referred to Asha, Joseph, and Renata. I also want to thank Catherine Howe and Farshad Nasiri, who will be chairing the oral presentations from our students. And we had well over 150 abstracts and mini papers that were submitted, and there's quite a rigorous review process, and I want to thank and acknowledge all of the reviewers of the oral presentations who are on this slide. And we will have a very vibrant e-poster session, and we really try to be very inclusive of all of the presentations. And I think it'll be a really fun, extremely vibrant session that will really encompass the breadth of basic science, translational research, clinical research in the various disciplines. And these are all of our e-poster judges and discussants. So thank you very much to all of these individuals. And these are photos of the 3 individuals that I've recognized, Asha, Joseph, and Renata. Many thanks to you. And also, in addition to Renata, we have a really wonderful administrative team, and you've met some of the people out in front, including Sylvia Perry, who work tirelessly behind the scenes to make events like this successful. And then we really do value your input very, very much. In the past, we would give you paper questionnaires. Now we're in the modern era. You got to take a picture of the QR code, which is, I think, out front, and it's in the various materials. But we really do value your input, in particular, ideas for, for future themes, future speakers, and, it's extremely important. So thank you, and on that note, I would like to hand things over to Dr. Catherine Howe, who will be chairing our first session. Thank you very much.
Morning, everybody. Nice to see everyone. Thank you. I'm one of the vascular surgeon scientists doing basic and translational research. I love the community here. I think it's an honor to be up here, so thank you for letting me be part of this morning. We do have one slight change in schedule, which just means we have a bit more time afforded to us. Unfortunately, one of our speakers has had a family medical emergency, so I'll guide us through the way, but we're thinking of them, obviously. Today, I'd like to welcome up our first speakers, so Matteo Ponzoni. I hope I say that name correctly. Please forgive me. He's one of the cardiac surgeon scientists who trained in Italy and Canada. You can read his bio, but he's going to talk to us today about mechanical stress-driven cellular senescence underlying progressive fibrotic remodeling in Fontan-associated liver disease. Welcome. Thank you.
Thank you. Thank you very much. It's really exciting to be here, and I want to thank you for the introduction and the committee for allowing us to present our work on trying to give you some new mechanistic insight on the development of Fontan-associated liver disease. I have no disclosures. So we know that the Fontan procedure has been a game changer in congenital heart disease. In particular, it allows passive blood flow to the lungs by bypassing essentially an absence of a subpulmonary ventricle. But in order to do that, it generates a chronic state of systemic venous hypertension. So nowadays we have more than 35,000 Fontan patients in North America, and this number is expected to grow in the very next years. But as the survival is improving, all these patients are facing a lot of extra cardiac comorbidities, especially Fontan-associated liver disease, which is basically universal in those patients after a certain amount of time. And we also know that this disease can lead to failure of the Fontan circulation in more than 50% of cases presenting with failing Fontan. So despite the clinical impact, there are very few mechanistic insights on this disease. So that's what we wanted to target in our research. Just to give you an overview about our previous research, we have been studying a lot myocardial remodeling under stress, under pressure overload. And what we found in the myocardium is that cellular senescence is a key driver of this adverse myocardial remodeling. And also we found that cellular senescence can be a precursor to irreversible fibrosis. I put a couple of pictures here of hearts from rats undergoing pulmonary artery bending. On the left, you see a staining beta-gal for the senescent cells that are depicted in blue. And on the right, it's a trichrome for the fibrotic area in blue as well. And as you can see, the area of fibrosis and senescence, most of the time, they tend to overlap. So our mechanistic hypothesis is that the myocardium and the liver, under similar stress conditions, so under pressure overload condition, may have a similar fibrotic cascade, where in particular in the liver, we have a chronic venous hypertension that basically drives a mechanical stress and that may activate integrin-dependent mechanotransduction. And also the mechanical stress can promote cellular senescence that will at the end drive irreversible hepatic fibrosis. So the aim of the present study was to develop and characterize a small animal model of Fontan-associated liver disease by partial bending of the suprahepatic inferior vena cava, and in this model to define the temporal progression of mechanotransduction, cellular senescence, fibrosis, and to validate these findings in human fold tissue. So what we did is, as I said, partial bending of the suprahepatic IVC in juvenile rats. We followed them up to 16 weeks. We did several biopsy along the way, and in a subgroup of animals, we removed the band to see if the modulation of the pressure overload and the congestion on the liver may modulate those pathways. And the matrix that we used by histopathology and also protein expression were, as I said, marker of mechanotransduction, senescence, epigenetic remodeling, and of course fibrosis. And the human cohort that we use for validation of our model was composed by Fontan patient, adolescents, 14 years of age, who underwent either surgical liver biopsy or post-mortem examination in the context of Fontan failure. And then we had age and sex match controls that were, of course, healthy non-Fontan livers. So these are some macroscopic images of the rat model. As you can see in the red box on the right, the IVC banding is basically generating this characteristic nutmeg appearance of the liver. It's clearly congested. There is a nodular surface, so really different from the normal liver. And when we did the stainings for the fibrosis, you clearly see that there is a progression of fibrosis with time, and especially we start seeing periportal fibrosis, and then with time also bridging fibrosis, and also we saw sinusoidal dilatation, as you can see from the last picture on the bottom right, that it's, the white is becoming more and more. That means there is a dilatation of the sinusoids because of the chronic mechanical stress. Then we wanted to see if the mechanotransduction pathway were activated, so we did some staining and some Western blotting for activating the integrin beta 1. And as you can see from the immunostaining, with time we have more and more signal that it's, and there is also the quantification by Western blot on the right, and clearly you can see that this pathway is activated. And then main point of our research was cellular senescence. So we started with some very common stainings that we were used to adopt in the myocardium. The first one in the red box is beta-gal. It's a classical staining for senescent cells. The cells which are senescent are blue. And as you can see, there is an increase of the amount of senescent cells. Then we did multiple other stainings for confirmation. One is P21, which is in green in the green box. And again, you clearly see that there is an increase in the intensity of the signal with time. We also did other markers of, again, DNA damage and epigenetic remodeling. And again, you clearly see that with time, there is an increase in the signal of these markers. That means there is a stress on the DNA, which is one of the driver of senescence. After that, we wanted to validate these pathways in human samples. So as you can see, starting from mechanotransduction, we use the same antibody for activating integrin beta 1, and you clearly see that the amount of green cells that are the one expressing this mechanotransduction pathway are way more bright and intense in Fontan patient compared to the controls. And then we checked also the markers of cellular senescence like P21. And again, in the green box, you clearly see that Fontan patients have a higher expression of P21. And on the bottom, there is H3K9 acetylation, which is a marker of epigenetic remodeling. In this case, it's in purple. And you clearly see that the Fontan patients have a stronger signal compared to controls. So the following step that we did in the animal model was to modulate the intensity of the mechanical stress on the liver and see how those pathway will respond to that. So we performed a removal of the band after 4 weeks, and then we terminated the rats at 8 weeks. So on the in the red box, you see the trichrome staining for the fibrosis, and as you can see, there is no change in fibrosis. So once the fibrosis is there, is as we know, irreversible. But if you look at the green box, where we have beta-gal staining for the senescent cells, we clearly see a senescent signal in the rats that are still under banding after 4 weeks. But after removal of the banding in the bottom right, you clearly see that the signal goes back to basically baseline levels. So that means that the senescence is a dynamic process and can be modulated. So to conclude, our small animal model of IVC banding can recapitulate the key mechanotransduction and senescent pathway that we observed in human Fontan-associated liver disease. And we found that senescence is a really dynamic process also in the liver, and it's mechanically regulated, in contrast, of course, to irreversible fibrosis. And all these findings support that cellular senescence is a mechanistic relevant pathway in Fontana-associated liver disease and a potential target for drug therapy. And just the final slide, what are the next steps? Of course, define the evolution of senescence and define the temporal window where it goes from reversible to persistent. Identify which cell types are senescent in the liver, and of course test the pharmacologic modulation of senescence. We have tons of senolytics that we can try nowadays. And then, of course, escalate to a large animal model. We can do a single-stage total pulmonary connection. We have some colleagues in Love and they did in sheep, so we are planning to do the same in piglets. That will increase the translational relevance of the findings. I would like to thank a lot my mentors, Dr. Coles and Dr. Mains, and of course all the members of the lab that helped with all the results. Thank you.
Great job. Thank you.
Thank you.
We do have a discussant. Is Dr. Greco here? Hi. Morning.
Hi there. Thank you for that. That's great pathways and understanding the liver diseases associated with the Fontaine for these children and adolescents. And I guess my question is, senescence does seem to be very dynamic, as you've pointed out, but the fibrosis still seems to be there. So is that really where we want to target? And if so, at what point are we going to be doing this to make sure that the fibrosis does not actually settle in and become irreversible?
Thank you very much. That's essentially the key question we are trying to answer with the next investigation. So what we are doing is trying to see in different time points by modulating the stress, how the senescence responds and also how the fibrosis responds. So, and on a parallel way, modulating the senescence by drugs, by senolytics or xenomorphic, that will be another line of research that we are starting to do. Essentially by keeping the pressure stress, but just targeting the senescence with drugs. That will also reply to this question: if we modulate senescence only, then how it will affect the irreversible, like injury or fibrosis in the liver.
I have a second question, if that's okay. My second question is, do you think, because there's been a lot of drugs already that have been tried, right? Like looking at the research in preparation for this, there have been a lot of drugs that have been tried. So where do you think, or how do you think your research is going to change that? Because they've tried ACE inhibitors like sildenafil, those like nitric oxide for the oxidative stress, et cetera. How do you think your research will change the pathways that, or the drugs that have already been tried? And do you think maybe it's not just a cellular level, but maybe we need to have a more 3 or 4 pronged approach where maybe we need to do TIPS earlier on, or really look at the anastomotic stenoses to try to reduce the added stress factors?
That's a very great question. So definitely the Fontana-associated liver disease, it's a very multifactorial disease. As you pointed out, the degree of congestion of the liver is one factor. Then, of course, cyanosis, low cardiac output, they all contribute. So our research is trying to kind of answer different questions. As you said, there are multiple senolytics and xenomorphic drugs that have been tried in other liver disease, not in Fontana-associated liver disease, and we know that they have a lot of side effects. So by using the one that I mentioned, dasatinib and quercetin, definitely those are not the best one, but at least they will answer to the question, if I modulate the senescence, what is gonna happen? So that's definitely the answer, and I agree that that's not the best drug. In our prior myocardial research, we have been working with cytokines, and one of the cytokines we identified that has anti-senescence properties in the heart, that's one of the ones that we want to test in the liver. So that would be a more xenomorphic strategy. And finally, another question that we can answer with this model is also timing and the indication for heart versus heart and liver transplantation in Fontan. So that's another question that we can try to help reply to.
Take another question.
Good morning, Casper Wong from Sick Kids. A very fascinating work, and clearly you're on the right path here. My question pertains to your model, which is done in 2-month-old rats. Obviously, that's adult or near adult size. So my question to you is there something distinct about the Fontan-associated liver disease in children that is related to the Fontan, or is this a more generalizable phenomenon with cellular senescence affecting liver, causing liver disease due to outflow obstruction?
So that's a key question. So unfortunately, our Fontan human cohort are adolescents. It's really rare that we biopsy children with Fontan circulation. So unfortunately, all our validation data are from adolescents going on, where actually the disease is starting to appear. We did also a clinical study using MRI to evaluate the liver fibrosis in adolescents, and we know that around that age, similar age, around 13, 14, 30% of essentially asymptomatic Fontan, they have significant liver fibrosis at the MRI. So actually, we don't know if there is any difference in the younger Fontan. I assume so because we found that the fibrosis degree is time dependent. But definitely there are very few data on Fontan liver in smaller kids just because we don't investigate them.
But do you think that the adolescent or pediatric liver responds differently than the adult liver?
Well, that's so we know that definitely there is a change in the myocardium response to stress. I assume there might be also in the liver. The next step that we are trying to do is expand our human cohort data and trying to see if there is a different expression of those markers depending on the age. Unfortunately, now this cohort is just 10 patients. It's not enough to do this demographic analysis, but by expanding the cohort, that what we are aiming to try to characterize also in terms of anatomy, for example, dominant right versus dominant left ventricle, and of course age and type of Fontan, if those pathways are modified by the type of disease or the demographics, yes.
Thank you.
Thank you.
Phenomenal. I'd like to talk to you later. We've been doing work on endothelial senescence. There's a lot of work on which cells might be involved, so I'd love to chat with you later.
Okay.
Thank you.
Thank
Thank you
you.
very much. Congratulations. Okay, we unfortunately don't have Ziad giving us his talk today, so we do have our thoughts with them and their family. And today instead, I'm going to be inviting up early Christopher Lozano. So a big name around here, a big person. You can read his bio, but today Christopher is going to talk to us about returning home after a spinal cord injury, a population-based evaluation of healthcare costs, recovery, and value. Hi.
Okay, thanks for the opportunity to speak. My name is Chris Lozano. I'm a fourth-year neurosurgery resident and doing my PhD here in clinical epidemiology under the supervision of Dr. Jefferson Wilson. So my research focuses on better characterizing recovery after traumatic spinal cord injury. And I just wanted to start with, a clinical vignette of a typical patient that we would see on call as a neurosurgery resident. A young man, he's in a motorcycle accident on the 401. He's flung off his motorcycle and has a thoracic fracture, and he has a spinal cord injury, and he's paralyzed and his leg's down. And as the neurosurgery resident on call, we're frequently the first person to speak to this person after they've had this devastating injury. And they have a lot of questions, many of which we can answer with the data that we have, in terms of their expected neurologic exam recovery. But many of the important questions that they ask us, we don't have good data to answer. And these are things like, what's my life really going to look like over the next 6 months to 1 year? And am I ever going to make it home? And this was really the rationale for me taking on this research. So traumatic spinal cord injury is a devastating, life-altering illness that causes major long-term disability. And it affects around 20 million people worldwide with a staggering number of new cases annually. And each of these cases is associated with an immense healthcare resource cost, estimated between $1 to $5 million per person, depending on the level and severity of their injury. And as I was alluding to, the problem that we have as clinicians is that we don't have an outcome measure that's readily interpretable to these patients. We can tell them that their ASIA score is going to improve from an A to a B at 1 year, but that's not really interpretable by patients. and it doesn't actually capture the entirety of their recovery process. And so this is where I wanted to investigate this novel outcome metric called days alive at home. So as you can see, as a patient has an injury, they have a continuum of their recovery from the acute hospital stay. They may go to the ICU, they may die in the hospital, then they can eventually go to rehab and eventually home. And we want to count how many days within the first 6 months or 180 days after their injury are they actually spending outside of these medical institutions. And this has very high face validity for patients. They can easily understand, okay, I'm expected to have 30 days at home, 90 days at home within the first 6 months of my injury. So my first objective was to measure and validate this metric, days alive at home, within the first 180 days after spinal cord injury as a patient-centered metric of recovery. So I conducted a population-based retrospective cohort study of adults presenting to trauma centers in Ontario with traumatic spinal cord injury between 2009 and 2023. This is using ICS administrative health data, and we can actually capture the entire continuum of the patient's care in this data that's routinely collected in every patient. And I wanted to measure this days alive at home within 180 days and then validate this metric using quantile regression to look at associations with different clinical factors and demographic factors, and also to relate it to an existing measure of recovery, which is called the functional independence measure, which we assess at rehab. And so these are the results here. As you can see in this histogram, we see that the overall cohort, there's a massive spike of patients that have 0 days at home. And what that means is that these patients either died or they never left the hospital in the first 180 days after their injury, which is quite staggering. But if we break this down even further into different injury phenotypes, like a cervical complete injury, which is the most severe form of injury, we see that these patients with 0 days at home are predominantly dominated by this 0-day phenotype. If we look at this quantile regression, where we're trying to see what factors are associated with more or less days at home, we see that patients that have incomplete spinal cord injuries are associated with more days at home, and then patients that have a higher injury severity score, or a sign of polytrauma, essentially, frailty, and also increasing age, are more likely to have less days at home. In addition, our days live at home within the first 180 days was independently associated with higher functional independence measure scores at rehabilitation discharge. My second objective was to develop and validate a prediction model for poor home time recovery. So can we actually predict which patients are going to have a poor recovery? So again, we did a population-based cohort study, a similar cohort. Our outcome measure in this case that we were trying to predict was having less than 90 days at home within that first 6-month period. I compared different models, both conventional logistic regression models, but also machine learning models, and did internal validation with bootstrapping and also temporal validation. So we had a cohort that we split into 2 eras, 2009 to 2020, with around 669 patients, and then a temporal holdout set to test our model on between 2021 and 2023. And the predictor variables that we used in our model were informed by the prior work that I did, but also things that we know that are clinically important from the literature, such as having early surgery within the first 24 hours of injury, which is a benchmark that we strive for. What we found was that I compared 5 models, and the logistic regression with a non-linear age variable, so a splined age variable, had the best balance of discrimination and calibration. And so we use this model to then create a risk prediction tool, which we can deploy easily at the bedside using very basic clinical variables that still has a high discrimination. And the idea is that we can now use this as like a phone app or a computer app when we're at the bedside and speak to patients about their expected recovery. The last objective that I wanted to look at was, can we relate this value of days live at home into healthcare cost during recovery? Is there a relationship between these two? And so again, we performed a retrospective population-based cohort study, again using the ICS data. And the beauty of our public healthcare system in Ontario is that every single healthcare transaction is actually recorded in the data, and we can actually go back and look at these patients. What services did they have? Did they have surgery? Did they have physiotherapy? Did they go to rehab? And we can summate all those costs into an estimate for each patient. And so we did a model where we looked at healthcare costs versus days live at home while accounting for confounding variables like demographic, clinical, and injury factors. What we found here, this is just a cost trajectory where we looked at the costs at different intervals. And as you can see, there's very high front loading of the costs. This is when patients have surgery, they're in the ICU, et cetera, in the first 30 days to 90 days. And we again see this separation of phenotypes where the cervical complete patients have the highest costs, around $100,000 within the first 30 days, which is quite staggering. Then if we look at the cost versus days live at home, we can see again this splitting of phenotypes where the patients with the most severe phenotypes with complete cervical injuries have much higher costs per day alive at home compared to the less severe phenotypes. And furthermore, when we did multivariable cost modeling where we controlled for confounding variables, we observed that a 10% reduction in the cost was associated with additional 100 days at home within the first 2 years of injury. So a potential mechanism to reduce our healthcare costs by getting patients home sooner. So in summary, recovery after spinal cord injury can be measured in a patient-centered way using days alive at home. Days alive at home is clinically meaningful. It's associated with injury severity, age, and frailty. Poor home time can be predicted accurately using simple demographic variables that we collect when the patient comes in initially. We don't need any extra data collection or fancy questionnaires or anything like that. And getting patients home sooner and keeping them home, meaning reducing their complications, making sure that they get the rehabilitation that they need, can be associated with lower downstream healthcare costs. So why this matters is that this metric, days alive at home, is patient-centered. It captures what patients matter most, getting them home to be with their family, not just living in the hospital. It's clinically actionable. It enables us to risk stratify patients based on their different characteristics. And it's also system relevant. We can link this to healthcare utilization and costs, which has implications for further research and planning. So I just want to thank my supervisor, Dr. Wilson, my committee, and also thank you to the many nurses, allied health, and physiatrists that take care of these patients, and obviously thank you very much to the patients themselves. Thank you.
Great job. Thank you. Really, really enjoyed that. We do have a discussant. Well, that's going to be Jonathan Persitz. I will wait. I have questions, but I'll wait. I always have questions. So really nicely done.
Awesome work, super impressive work with ICS. I'm Jonathan, I'm a hand surgeon in Toronto West. I'm also a scientist at ICS. I have one question regarding your FIM, or the functional independence measure. So you found that greater FIM is associated with lower cost in other findings. I think the main thing with working with ICS or any administrative health data is essentially you have to look at a macroscopic level. You can't look at a microscopic level, per patient. And did you have access to baseline FIM? And do you think it's important to have, baseline FIM when you interpreted your results?
Yeah, that's a great question. So, when you say baseline FIM, do you mean like after the injury, or like, so?
Actually, before the injury.
Before the injury, yeah. So, I did not have access to baseline FIM because this is essentially, my understanding is that the FIM is something that's done at rehabilitation admission and discharge. So it's the average person in Ontario, unless they've been to rehabilitation before, they wouldn't necessarily have that data. I'm sure there's possibly some patients in the cohort that perhaps had baseline FIM before the injury, but I suspect it'd be a very small percentage of those patients. That being said, in this, I didn't show it entirely, but in this cost analysis, I actually did look at the change between rehabilitation, admission, and discharge. So the association that I saw between costs was actually the associated with the change in FIM score. So in other words, the patients that improve over the course of their rehabilitation course, those are the ones that are associated with reduced cost. So in other terms, if a patient goes to rehab and they make a lot of functional gains, that is associated with the reduced costs.
That's great. My other question is, how did you adjust for residual confounding throughout the manuscript?
Yeah, it's difficult, as you know, with the administrative health data. You're somewhat limited in the granularity of variables that you can use because you're not capturing, for instance, like in spinal cord injury, we don't have the actual like Asia motor exam score, that kind of thing. You're kind of are limited by the granularity of the variables. What I did was I tried to pick variables that could act as like surrogates for things that we don't actually capture. For instance, like using frailty, and also using like prior home care use, these things that are kind of like markers of increased comorbidity that you may not actually get all those variables captured within ICS. By using these kind of surrogate markers, you can try to capture all the unmeasured confounding. I didn't actually, in this work so far, I haven't actually measured unmeasured confounding formally yet, but that is certainly something that I could do.
Fantastic work.
Thank you.
Really nicely presented, Chris. Just sort of carrying on the theme of the limitations of administrative data, I can see how on the surface of it, you're an acutely injured patient, hearing that you're going to have so many days at home, most likely, sounds really good, but what is your thought about the actual quality of life of these individuals once they're at home? And also from an equity lens, you know, are there people in a higher socioeconomic status who are able to, their families are able to get them home, and then others who are, you know, resigned to complex continuing care?
Yeah, that's an excellent question. So obviously, this is, as I was saying, you know, a bit not a granular measure of certain things. Like someone that's home, they can technically have a similar amount of home time, but depending on, you know, their care needs, what it actually looks like, their life may be very different. Are they, you know, do they have a tracheostomy? Are they on the ventilator, et cetera? So that's definitely a limitation of this, that this is more of a zoomed out picture of are they home, are they not? But I think community dwelling in and of itself is a goal of rehabilitation in spinal cord injury that patients resonate with. So I think just getting them home to be with their family is an important enough you know, outcome. In terms of, you know, the equity side of it, I totally agree. Certainly in the US, we've done work in our group that shows that there's insurance-related disparities in access to rehabilitation in the US, and also insurance-related disparities in access to time to surgery. So patients that have different insurance, you know, they're less likely to have timely surgery, and therefore it affects their outcome. I think in Ontario, or in Canada, the strength of our healthcare system is that many of those systemic barriers are actually eliminated. And for instance, any patient that presents to our hospital will have access to rehabilitation regardless of their socioeconomic status. That being said, I recognize that, you know, things don't always work out in a perfect way, and therefore I controlled for something called the Ontario Marginalization Index in my analyses, and this includes 4 dimensions of marginalization, one of which is called the material resources dimension, which is like a measurement of access to these kinds of services. So despite after controlling for that, it was not a significant factor in determining days alive at home.
A more short question and short answer.
Okay.
That's okay.
Hey, I'm Dave. I'm one of the plastic surgeons at Sunnybrook. I deal with a lot of these patients at the end of their acute journey. I run the wound care service, and so we see a lot of patients with pressure injuries and do reconstruction for them. My question to you is if you were able to capture any of that data, because what we're finding is a lot of young patients, specifically trauma patients, can't get to rehab because they have wounds. We can't do reconstruction on them because rehab won't take them. And then if they go home, their wounds are exacerbated, so they come back to hospital. So I was wondering if you were able to capture any of that in your data. Well done.
Thank you. Yeah, so that's an excellent question. I didn't capture that directly, meaning we didn't necessarily measure the patients that are being admitted to a hospital or readmitted to a hospital specifically for wound complications. However, it would be captured at like a macroscopic level within the days alive at home, because if a patient, let's say they make it home, but then they're having a pressure ulcer or something like that that ends them back up in the hospital, that admission would actually be captured in the measurement. But certainly we are doing work to look at these more specific complications of spinal cord injury, including pressure ulcer, wound complications, and looking at different factors associated with those things.
Thank you. I'll find you later.
Okay.
Question.
Thank you.
Okay, we're doing okay for time, so I'm going to welcome up Natasha Barone, or Barone. Please do correct me on the last name. Okay, she's going to talk to us today about dorsal versus palmar approach for trigger finger corticosteroid injection. A randomized control trial, a patient reported.
Thank you. Thank you, everyone. It's a pleasure to be here today. So I have no conflicts of interest to declare. To begin, trigger finger, also known as stenosing tenosynovitis, is one of the most common conditions that are seen by hand surgeons in clinic. A typical patient will present with the constellation of symptoms, including clicking or locking of their fingers, which is associated with pain. When this disease progresses, ultimately a patient can show up with their fingers stuck in a flexed position, requiring them to actually use their other hand to flick it upwards to put it back into extension. The underlying pathophysiology of this condition is usually one of the two. The tendon ultimately is inside of a canal or a flexor sheath, which has to glide normally. So you can imagine that if either the tendon is inflamed or there is thickening of the tunnel, this cannot happen, and that ultimately is what causes the clicking, locking, or getting stuck in that position. And just on the other side of that, what we can see is just a showing of what the flexor sheath actually looks like, which is a combination of different pulley systems in the finger of the flexor sheath, of which the A1 pulley is the place where the most common amounts of clicking and locking occurs. So in order to treat this condition, the two most common approaches are either corticosteroid injection or surgery, for which patients are typically counseled in order to get up to 3 corticosteroid injections prior to progressing to surgery. And this injection ultimately allows for inflammation to help be controlled at this level. However, these injections typically are very painful for patients, which we'll discuss a bit on the other side. So the question becomes, can we help reduce this pain in this patient population? So the most common approach that is used for trigger finger management in terms of corticosteroid injection is a palmar approach. The palmar side of the hand, as you can imagine, is what we use to touch and feel everything around us. So it is highly evolved to be very sensitive and has very glabrous skin. So when you have an injection which goes through, that can be very painful for patients. An alternate technique, which is less used, is the dorsal web space approach, which we'll discuss today, which is ultimately where you come from the dorsal side of the hand to inject in the finger to get to that A1 pulley to help, again, with the corticosteroid, reduce the inflammation in the finger. In order to get a better understanding of the literature, we performed a scoping review in order to see what the current literature stands with regards to the use of the dorsal web space approach. And what we were able to see is that ultimately there is some data that suggests there may be a slight significant improvement in pain, safety, and similar clinical effectiveness to that palmar approach. So ultimately, this led us to our objective to compare patient-reported pain measures of trigger finger corticosteroid injection performed either through the dorsal web space or the palmar approach. And our hypothesis was ultimately that the dorsal web space approach reduces this post-injection pain without reducing clinical effectiveness. And so in order to be eligible for inclusion in our study, patients had to be 18 years of age, have a trigger finger diagnosis in any digit, and choose to have corticosteroid injection. In terms of exclusion criteria, patients who are unable to communicate in English, declined an injection, or had previous injections or multiple injections the same day were excluded. So this was a single center, single surgeon, unblinded RCT that occurred from July 2024 till August 2025. And essentially we followed the process of doing enrollment and consent, one-to-one block randomization, then injection with corticosteroid either through the dorsal web space or the palmar approach. And then pain was followed immediately after the injection, 4 hours or 24 hours following. And then relapse was assessed at 6 months. And then the primary exploration, was an exploratory analysis. So in terms of the intervention, all patients received a combination of steroid with lidocaine, which is the typical cocktail what patients will receive in order for their trigger finger injections. And then the patients were randomized either to get the dorsal web space approach, which is the intervention, or the comparator, the palmar approach. So our primary outcome was the patient-reported pain measures, which is the numeric pain rating scale, the visual analog scale, the pain present intensity index, or the short form McGill pain questionnaire, which again were measured at 0, 4, or 24 hours. The first form was done in clinic and the other two were done remotely. And so just to touch on the scales a little bit, the numeric pain rating scale is a scale of 0 to 10, where patients will ultimately give a score to say if they had no up to the worst pain imaginable. Similarly, the visual analog scale is a pain scale where the patient will put an X on the scale, and that X will be converted into a number on a series of 10 to describe their pain. Next, we have the present pain intensity scale, which is on a scale of 6 markers. So the patient can choose up to no pain or excruciating pain to describe what they are currently feeling. And then the short form McGill pain questionnaire is actually a questionnaire that has 3 different components, of which I want to draw your attention to the first part, which is the throbbing, shooting, stabbing pain that they feel. This is where they characterize the sensory and affective pain that they're experiencing. And the other 2 scales below are the ones we've already discussed. So in addition to our primary outcomes, what we looked at was relapse at 6 months, which was assessed by either coming back for a second injection or any harms or complications associated to the procedure. In terms of statistical analysis, we had 60 patients per sample size. We used students T and Mann-Whitney for continuous and Chi-Square and Fishers for the categorical. We used a mixed effects analysis to look at our pain measures. And then we followed patients until they were missing data, and we were blinded to analysis, and a statistical significance of 0.5 was considered. So ultimately, 75 patients were eligible, of which 60 were ultimately included and randomized 30 to 30 per group. And then this just shows the different questionnaires and how many patients were followed at each point. So here what we can see ultimately is that there was no difference in the total age of the patients, that the sex was similar between groups, that the BMI also did not change, the most common comorbidity being hypertension, but there was no difference between groups. Most patients were non-smokers, and that patients were mostly working a desk job relative to a manual labor job, but again, no difference between groups. Regarding hand characteristics that are important to us in the hand clinic, the majority of patients were right hand dominant. Previously, there was no difference in if they had a previous injection, the number of injections they received, which injection or which finger was injected, and if they had surgery in the past for previous trigger finger diagnoses. So to touch on the pain data now. So this is our numeric pain rating scale. And what we can see here is that when we compare the palmar and dorsal approaches, there was a difference in statistical significance at 4 and 24 hours. And what we can really see is the trend. So you can see that ultimately the dorsal web space approach did have less pain. Again, on the present pain intensity index, a statistical significance was seen at 4 hours. But again, what we can really see is that trend that ultimately there is less pain in those patients. And again, this was shown through the visual analog scale, where patients, again, there was only a difference in statistical significance at 24 hours, but again, that trend is held. And this is just to show you those trends held across the different metrics. When we look at the short form McGill pain questionnaire, where we're looking at the sensory and affective symptoms like the throbbing, shooting pain, ultimately there was no difference in the types of pain that they were experiencing. And when we look at relapse rates, which again is a measure of if they came back for another injection or for a trigger finger surgical release, there was no difference between groups. So showing similar clinical effectiveness between the cohorts. So it's great that we talk about statistical significance, but what does this actually mean clinically? So in order to try and understand this, we tried to look at what would be the MCID, the minimum clinically important difference. And unfortunately, there's only one paper that has looked at only the visual analog scale. So the other scales, PPI, the NRS, none of these have actually been studied. So with regard to the visual analog scale, they do report that a vast difference of 2 is what they would see as an important difference. Now, while our cohort did not meet this, we thought that it was important that the fact that they may be experiencing less pain is still important for patients clinically, given, these patients will typically come back for repeat injections over time. Like I said, typically you'll do up to 3 injections before you even progress to surgery. So repeated trauma from pain. So the strengths and limitations of this work. This was a prospective randomized design with the same medication provided to all patients with multiple pain instruments, looking at predefined pain windows. It's directly relevant to hand surgeons. There was minimal resource supporting for implementation of the dorsal web space approach in clinic. And the limitations was obviously that it was a single center, single surgeon study. It was unblinded design with a modest sample size, and harms and relapse had to be measured retrospectively, and only English study patients were included. So what does this all mean? So for surgeons, this ultimately means that dorsal web space can be considered a procedure that they can offer to their patients. For patients, this could be a good alternative for patients who are anxious or pain sensitive or are returning for repeat injections. And ultimately, the next steps would be to perform a large multi-center, multi-surgeon study to test the external validity of our results. These are my references. Thank you.
We do have a discussant, Matthew McRae. Thank you.
Thanks, Natasha. That was a really elegant study. Really applicable for a lot of people like myself. I'm a hand surgeon at St. Michael's Hospital, and the one thing that's different is that dorsal approach is something that I have never used. So do you have any experience with that? I mean, there was the single surgeon who was doing the injections, presumably a master surgeon, in terms of the ability to teach this to trainees, or for the ability for trainees or other surgeons to implement this effectively?
Yeah, so Dr. Zoe was the one doing all the injections, but just because for standardizing in the study to make sure that the pain metrics were similar. But ultimately, I do think it's quite easily applicable because ultimately you're coming through the dorsal web space and you're kind of just pointing the needle volarly towards the A1 pulley system. So I do think that in terms of like teaching and applicability, it should be easy given, we do so much in the hand.
Right. Yeah, and I guess the other kind of anatomic piece is that coming from the dorsum, there's a lot of other things in the way that you could potentially disrupt. Do you think the placement of the injection has to be so specific that it can be done either way as effectively, or do you think it's kind of more of a regional effect of the steroid?
It's a good question. I think that, the steroid ultimately works on the environment. I do think it's important that you get towards the A1 pulley to help bring down the inflammation, but I do think it ultimately has to be within the flexor sheath in order to provide effectiveness. So I think obviously the way that they inject will matter to get it to the right place to help with that inflammation, to allow them to stop clicking and locking.
Great. And I guess the final thing on those, the 3 pain measures, it seems like you had basically statistical significance on all 3. And for the visual analog scale, you did mention how you didn't quite meet what they would say is the criteria for clinical significance. But for the other 2, do you have kind of a sense, based on that level of statistical significance being so significant over 3 different measures, and then just intuitively the skin?
I think, the first thing about the visual analog is that we used it because it's the most similar, but the patients were not exactly the same in the sense that some of the patients were getting corticosteroid, others were getting splinting, or both. So it was the most clinically applicable to get an idea. For the other scales, I mean, overall, I do think that it would be expected to have less because, like as I was explaining a little before, right, the hand, we use it a lot for touching and it's a lot more innervated, and like the glabrous skin is more sensitive. So coming from the back should be ultimately less painful. So I do think even though we couldn't meet that statistic, or not the statistic, the VAS for everybody, we had up to like 1.2, and there are other scales that are a little bit less hard. Like that was an anchor-based approach that gave the VAS of 2, but there are means that they use, like that say that 0.6 is what's significant. And ultimately, technically we could have used that, but the reason we didn't is that it basically says that the patient's input is not as involved in that analysis. So that's why we docked ourselves a little bit choosing the higher scale, but feeling that it was more quote-unquote relevant to the patient, if that answers your question.
That's great. Thank you so much. I'll let Dr. Forrest ask a question as well, but really an amazing study, I think, in a lot of ways, because there's not a lot of presentations I see where I actually will implement a change in practice, so that's really fantastic.
Thank you. Chris Forrest from Sick Kids. Natasha, that was a lovely and very eloquent study. Pain is something that all of us in this room have to manage as surgeons. And it always strikes me that it's highly subjective. And I'm wondering in your cohort if you had the opportunity to do any substratification to determine whether things like hand dominance or age or sex had any variation in terms of the types of symptoms and pain scores.
Yeah, in terms of like hand dominance, the patients were like 95% all right hand dominant. So I think it'd be hard to stratify on that. I haven't done on the other one, but we could definitely look at that and see if there's a difference, because obviously in other areas, men and women do differ. So I think that would be a next stage as we finish writing up the paper.
Great study. Thank you very much.
Thank you so much.
Thank you.
Thank you.
Okay, I'm going to welcome up Matthew Raleigh. He's a fifth-year orthopedic surgery resident. He's going to be talking to us today about endothelial progenitor cell therapy for treatment of non-unions towards translation. Exciting. Thank you.
Thanks. Okay, well, thank you very much for the opportunity to speak today. We'll be talking about my work that was completed during my SSTP period, where I was supervised by Dr. Aaron Noth, where we looked at endothelial progenitor cell therapy for the treatment of non-unions, working towards translation of this therapy. So non-unions is a big challenge in orthopedic surgery. It's fairly common that patients will have a fracture that doesn't heal, at least 10% of the time. And patients really suffer with these injuries, and it's a big challenge for orthopedic surgeons themselves. These often require multiple procedures to eventually get the bone to heal. And our current therapy is to basically take bone from elsewhere and to transplant to this spot that's not healing via autologous bone grafting. That has some challenges though. It limits the amount of graft volume you can take. There's significant morbidity to the surgical site where you take it from. And it doesn't always work. So one of the approaches our lab has been looking at trying to take to solve this issue is with endothelial progenitor cells. So we've been looking at this particular cell population for several years, and it's shown very robust healing in preclinical models. In this case, our group uses rat cells, but you can also use sheep cells or pig cells for those purposes, applied autologously, and you get very robust healing. You can see an example here where a control rat has a persistent defect versus the one treated with locally delivered EPCs has a completely healed bony defect. And while there's quite good evidence here, it's conserved across species and the preclinical evidence is good, it hasn't quite yet been translated to clinical studies. So that was really the thrust of my sort of master's work here is, can you try and see if this is worthwhile to translate and see if maybe this would be something you could add into your treatment for non-unions clinically. So to do that, you have sort of two problems. If you want to test human cells, then you can't necessarily jump right to humans. Ideally, you want to demonstrate this in a preclinical translational model. For us, we use rats, and so we want to look at developing, therefore, a xenogenic model, one that's between species that I could test human cells in a rat model that would tolerate it, and then evaluate that healing. But to do that first, we need to actually establish a proper xenogenic model that would allow us to evaluate human EPC's healing capacity. So that first order of business was to establish that model. It wasn't well known exactly to what degree of immune deficiency a recipient would require to tolerate this discordant xenograft. Obviously, a human cell, or what we used here was a set of pig cells, to test this. It wasn't known at what degree of immune deficiency would be required for them to tolerate those xenografted cells. So the first order of business was to determine the degree of immunogenicity, and then also determine, okay, were we seeing similar degrees of healing with this model or not? That would justify its use to test human cells thereafter. So we used pig cells because they're readily available. They act as a nice transition between a rat and a human, and it would provide a strong sort of immune challenge to those recipient animals. So the three different models we used was a T-cell immune deficient rat, a immune suppressed rat, we call it the IS model here. This animal had a subcutaneous osmotic pump that delivered tacrolimus throughout the study, which yielded T and partial B cell suppression. Then the most immune deficient model we used was a SRG rat, which is a Sprague-Dawley background animal. It's double knockout, so it's B, T, and NK cell deficient. So this provided us with a range of degrees of immunodeficiency where we could evaluate whether or not these porcine EPC cells would be tolerated or not. It would demonstrate similar healing. So we took porcine EPC cells from the proximal tibia of Yorkshire pig shortly after the demise, expanded them in culture using established protocols, very similar to the ones we had been using in rats in our previous studies. These have been previously established by other groups. We expanded these in culture, we seeded them onto a collagen gel foam scaffold, and then delivered them into a 5mm critical size defect in the right femur of all these animals. So all the rats, regardless of their degree of immunodeficiency, had a 5mm defect created, stabilized with a plate and screws, and then had these cells delivered at the time of this defect creation. After 10 weeks, we evaluated the bony healing as well as the immune response in these animals to try and suss out what would be driving possible rejection or tolerance. So for bony healing, we looked at x-rays to give us a qualitative assessment of healing, micro-CTs for the quantitative assessment of healing, and then torsional mechanical testing to give us a functional assessment of healing and whether or not that bone had actually healed for a structural graft. With respect to the immune response, we wanted to look at the cellular and humoral immune responses, and so we collected plasma at the time of, serum at the time of the 10-week mark at our endpoint of the study, and then co-incubated this with the porcine EPCs, and then used flow cytometry to assess the degree to which IgM or IgG had been formed against these porcine EPCs that had been transplanted into those animals. Likewise, our cellular immune response was assessed via mixed lymphocyte proliferation assay, so we took splenocytes at the time of animal harvest and co-incubated these again with the porcine EPCs and looked at the proliferation. So look first at the bony healing response. We can see that the most immune deficient animal, the SRG group, had the most reliable rates of healing, about 80% rates of healing, and had the highest radiographic score when evaluated by blinded orthopedic surgeons. When we then looked at the degree of healing quantitatively using micro-CT, the absolute and relative bone volume created in the SRG animals was the highest, unsurprisingly. You can see that demonstrated there in the 3D reconstructed micro-CT image on the left. Most importantly, looking at the functional outcomes here when subjected to torsional mechanical testing across all 3 outcomes, the SRG, or the most immune deficient animal, had the highest degree of healing. Importantly, what you'll note here is that only the SRG animal actually developed a mechanically robust construct that would allow you to test this via torsional testing, and so that's the only one that actually had a real clinically relevant healing. We looked at what may be driving some of these responses and rejection. We saw there wasn't really much difference with respect to the cellular response, but there was a large difference in the humoral immune response, where the SRG animals, perhaps unsurprisingly, generated no IgM or IgG against the porcine EPCs, and that's likely the relative rejection for our xenografts. So in this case, we established a xenogenic model that would tolerate a discordant xenograft. We saw similar healing rates to what we had seen in our autologous study using rat cells, and this let us know that this SRG model would likely be appropriate to use for testing our human EPCs, which is really the goal of this study. So the next step of the work here is to test the viability of human EPCs for potential clinical translation. So we had 2 goals here. 1, assess whether or not they're effective in this xenogenic model. And 2, what we want to do is refine our protocols with the eye towards potential translation. One of the questions in the literature is whether or not peripheral blood or bone marrow-derived EPCs are equivalent for the degree to bony healing. And so what we wanted to do is establish, well, should we be taking stuff from bone marrow or from peripheral blood? And this make a big difference to when you're trying to study and design a trial as to whether or not you have to do an aspirate or peripheral blood collection. And so we wanted to establish those methodologies for future work. So to evaluate these questions, we generated 3 groups: a control group, which just had a defect that was treated with the empty gel foam scaffold, and then 2 human EPC groups from peripheral blood and bone marrow. In the peripheral blood EPC group, we collected blood via peripheral blood apheresis, and then isolated and expanded the EPCs using established protocols that have been used in a randomized controlled trial by another group for the application of peripheral blood EPCs for cardiac purposes. The bone marrow-derived EPCs were collected from patients that were undergoing elective total hip arthroplasty. We aspirated the subacetabular bone, and then these cells were both expanded in culture in a GMP-grade facility under the same protocols. So really the difference here was just the source of these cells. In both groups, a male and female donor under the age of 50 that were otherwise healthy and appropriately matched were used. So following collection from the respective sources, expansion in culture, they delivered again onto a collagen gel foam scaffold into a critical size defect, in this case only into those SRG rats. After 10 weeks, we evaluated the bony healing via X-ray for qualitative assessment of healing, micro-CT for quantitative assessment, and then functional mechanical testing via torsional testing to failure. Looking first at the union rates overall, again, we found the bone marrow-derived EPCs had the most reliable rate of healing, about 90%, so all but one of those animals had generated radiographic healing, with similarly greatest radiographic scores, though not statistically significantly different. Some results were demonstrated in the micro-CT study, or findings, where we demonstrated both absolute and relative bone volume, were greatest in the bone marrow-derived EPC group, again, non-statistically significant differences. Most importantly, most tellingly here is in our functional assessment of torsional testing to failure. And while again, we don't see statistically significant differences, what you can see here is if you look individually is that all but one of the animals treated with bone marrow-derived EPC generate a functional robust union across the defect site, versus half of those or less in the peripheral blood-derived EPC group or in the control group actually generate a true union. So while not statistically significant, it's a big clinical difference if you have about 90% rate of healing versus 50% or less. So overall, human EPCs were able to heal these bony defects, and that bone marrow-derived EPCs seem to be the optimal source for the treatment. Provide some evidence and some refined protocols for future studies, and our next steps now are to characterize the effectiveness of EPCs from aged and diseased donors to see if those effects persist. So thank you again for the opportunity to speak.
Fantastic. Thank you. You're welcome up. John Marshall, our discussion.
Yeah.
Okay, well, thank you very much for that very clear presentation of your work. I have a couple of questions for you that really stem from my basic ignorance of orthopedics and non-union. So the first relates to the question of the biology of non-union. Is this a absence of factors that would promote healing, or is it perhaps the presence of factors that would inhibit it? Because it does speak to your model and whether or not your model is providing things that should be there, or even perhaps, given that you've a little bit unclear about the use of an immunocompromised model, whether you're simply correcting the immunocompromise and therefore altering the model as opposed to changing the biologic process of healing. Could you maybe comment on that?
So I think your first question was, what causes a non-union, I guess, fundamentally, is that more or less? Yeah, so, I mean, clinically, it's a number of different ways. So in this case, we're using what would be representative of an atrophic type model or a bony defect. So you can see that bone forms, but it can't bridge the gap. It's too big of a biological challenge to, in this case, a rat, but if you made a similar size defect in a human, it'd be too big of a challenge. So that's really an issue of sort of biology, but on the standpoint of the insult's too large. You can have other atrophic models where you have patients that are diseased, and so highly comorbid, patients with diabetes, smokers. These are all patients that we know also have a tendency to form atrophic non-unions as a result. Also, you've got a lot of soft tissue stripping, like, again, in a big open injury. The other possibility is an infectious model, so we have done that as well, actually, with these cells, but if you use an infectious model, that also inhibits the degree of bony healing. So that's kind of the biology here, and the idea here is this is an atrophic non-union model specifically, and it's pretty commonly used in the animal studies because it's challenging to get a consistent degree of injury if you sort of, let's say, hit a shin or a femur with a hammer, just as the broad strokes. Your second question was then basically, is the effect that we're seeing because of what we're adding or an absence? Is that more or less?
Correct.
Yeah. So we do provide a collagen scaffold in the control groups and in the, obviously when we're delivering the cells. The cells themselves are likely promoting the sort of idealized immune environment, actually. It probably has more to do with anything, because bony healing in general is a complex sort of, initially you have an inflammatory response, and then that inflammatory response needs to leave so it can actually facilitate and promote these sort of osteoprogenic cells that will come in. So if you don't have an immune response at all, you won't actually generate appropriate bony healing. So there's a balance there. And what we think these cells are doing is they hang around for some time, but they aren't necessarily there the whole time. And they're probably not actually becoming an osteoblast or an osteocyte. They're probably signaling cells to come in, and that's more the role that's going on there. So likely, I suspect, when we deliver these cells to, in this case, it's a large defect that would otherwise be challenging or too difficult to bridge. It's basically giving a large signal and trying to facilitate that. It's almost adding like the sort of signaling cascade that you would need.
So that actually led to my second question was, have you tried other stem cell types as opposed to EPCs?
Yeah, so our group has not. They've been well explored by others. So a lot of people, what they've done as well is they've combined these cell types with mesenchymal stromal cells. And that's kind of a classic building block for a lot of the connective tissues. And those work well. These also work well on their own. And so mesenchymal stromal cells with these actually provide also some benefits for modulating the immune function as well, because the stromal cells also have that effect. Yeah.
Yeah, really nice work, Matthew. So my question kind of relates to maybe some controls. And so, inflammation is important for wound healing and is important for the healing of bone tissue. So you've been studying RNU rats and various ways to immunosuppress. Did you do any experiments with control naive rats where perhaps you're not maybe creating such a large defect, but to actually assess the impact of suppression of the inflammatory response on the bone healing? And I'm kind of getting to, just kind of looking at the underlying biology of your model.
Sort of in the sense of basically if you take away the immune suppression, what happens without delivery of cells in and of themselves, and then what happens when you take out the specific components? Yeah. So So people have kind of done that work. We have not. Dr. Nam, actually, I don't think she's here today, but she works at Sunnybrook, one of the surgeon scientists there. And she's kind of looked at basically each individual sort of cell, what's their role there. So if you look at the predominant cell that's going to determine a large degree of how the bony healing seems to be dictated, certainly neutrophils and macrophages early on, but T cells are very important actually to the bone that you form. So if you take away T cells, which we do in that one, basically the model that we used here, what you do is you get essentially a stiffer bone. It's more brittle, essentially. So you get less collagen deposition, and so it alters the degree of sort of bone that you form. If you also take away macrophages and neutrophils, if you don't get that initial immune response, you really don't get any bony healing at all. You kind of just get this fibrous. So that's, we haven't studied that directly, but it has been sort of studied. So yeah, this model really, as I was kind of getting towards, is it has issues from the standpoint of, I don't think we're going to be using SRG rats or anything like that, but the idea was I need some way of evaluating human cells before I can translate, and so I need to get something that will tolerate it. So you sort of, sacrificing some of the ideal biology, but we kind of know it works, and so we had to sort of take that and, balance it out.
Okay, thank you.
I am going to ask
Yeah.
a question, if that's okay. I love the talk, it's great. I realize there's a lot of biology to discuss and think, and one of the ways, if I sort of distill it down to a nutshell in my mind that's amazing, is that maybe these EPCs are just setting the stage, right? So it's about endothelial or EPC communication. Is there a way that you can leverage maybe extracellular vesicles or some other form of an endothelial sort of communication tool that can be delivered, and then you can bypass some of the immune issues?
Yeah, that's a great question. That's kind of where that field is sort of going to some degree. As usual, orthopedics is a little bit behind everybody else. It takes a little bit longer for us. But yes, so there is a way of doing that. People have looked at using, the idea what you're getting at is basically the paracrine effects is probably what's driving it here. And we've kind of done some of that work. Maybe at some point so you can present that. But we have looked at basically looking at taking these cells and just essentially collecting the conditioned media from it and then isolating the vesicles from that. So I'll have to kind of wait until maybe somebody presents on that. But that certainly is a way you could try and move around that. I think to some degree though, it's whether or not, you have, if you think about like a bank's printing money, and then there's the money that's in circulation. You can put a bunch of money there, or you can be the one printing the money. If you're printing the money, then you can sort of adjust what you need based off the response. So I think there is some benefit by using a cell present because it can modulate whatever it's receiving. There's sort of a two-way communication versus if you provide vesicles, it's just a single sort of line of communication. You sort of drop that off. It's going to deliver whatever sort of paracrine effects and hormones that it has, but it's not going to necessarily have the ability to sort of adapt to whatever the response is. So I think potentially some benefit by having cells.
Maybe provocatively suggest that you just then deliver something so at the end of the cell releases that what you want. So basically get it hit with some cargo that it can deliver for you.
Yeah.
And just treat it like a bioengineering tool.
Right. Yeah, that's a great idea.
Cool.
Yeah, thank you.
Okay. Okay, I'm going to invite up William McIntyre. Thank you very much for joining us this morning. He's going to talk to us today about regional spinal cord identity of neuroprogenitor cells promoting balanced synaptic function and motor recovery following traumatic cervical spinal cord injury. Welcome. Thank you.
Thank you. Okay. Briefly begin to reiterate my study. Regional spinal cord identity of neuroprogenitor cells are able to promote balanced synaptic function and motor recovery following traumatic cervical spinal cord injury. So to reiterate my overarching statement or hypothesis of this work, that being that transplanted regionalized and specifically spinal cord neuroprogenitor cells are able to optimize functional recovery for cervical spinal cord injury. So I was lucky enough, there was an earlier presentation that contextualized a little bit of the burden on spinal cord injury itself. But briefly, SCI patients face detrimental physical disabilities, which require surgical intervention with lifelong support to regain minimal function. And to regain meaningful pre-injury-like function, therapeutic avenues need to address the multifaceted and complex cellular environment of SCI itself. So pathophysiology on SCI itself, so at a cellular level, mechanical trauma to the spinal soft tissue elicits a primary necrotic core in which neural cells are irreversibly damaged. So as peripheral immune cells begin to infiltrate into the spinal cord and cell debris accumulates, this expands the cellular death signaling within the spinal cord, which primarily eliminates oligodendrocytes, leading to eventual demyelination, eventual neuronal loss, which leads to synaptic imbalance, as well as the accumulation of reactive astrocytes. And so appropriately transplanting and replacing this lost tissue with neuroprogenitor cells, or NPCs, is optimal for spinal cord injury in theory, largely because they address this tissue loss by replacing the three major cell types of the CNS, that being astrocytes, oligodendrocytes, and neurons. Within the short term, they're protective and they can secrete pro-survival trophic factors. And within long term, they have the potential to integrate with the spared tissue and restore their lost functional deficits as they begin to differentiate. However, a large caveat, preclinically at least, is that there are many potential cell source candidates used for cell transplantation without very meaningful mechanistic explanations as what describes a optimal cell therapeutic itself. So notably, there have been several clinical trials to date that have assessed the general safety of transplanted neural progenitors, but currently they report minimal changes to sensory with very little to no improvements in motor function itself. And so a reason for this lack of efficacy could be the use of a mismatching or brain-derived progenitors within the spinal cord environment. And indeed, I'm just going to briefly mention this preclinical study, which outlines and directly compares a regional progenitor from the brain and spinal cord, and we see less innervation of host neurons, which are outlined in red in the diagram, integrating into a grafted brain cell, whereas we see a lot more innervation of spinal progenitors themselves. So overall, this informs the ability of the host to integrate with these regionalized cells. So this leads to some unanswered questions within the field that I hope to address during my presentation. So specifically, what intrinsically makes a neural progenitor cell different from the brain and the spinal cord, specifically whether spinal cord neural progenitor cells are able to improve motor recovery, and also whether these intrinsic features that we can define between regional progenitors, whether they're maintained following transplantation within the SCI environment. So primarily here, I have a principal component analysis that was completed following RNA sequencing of differentiated regionalized progenitors. And what we showed was a differential gene expression of the whole active transcriptome, so within the PC1 axis. So essentially how the whole active transcriptome clusters, we have greater than 50%, or we have 50% of the genes within each transcriptome are differentially regulated, and we see unique clustering of each progenitors to one another. And so when we dive into the mechanisms and the transcriptomics of these cell types themselves, we see that spinal cord astrocytes and neurons are very different than brain-derived neurons and astrocytes. So specifically, spinal cord-derived astrocytes are largely homeostatic. They regulate a lot of synaptic functions, as well as regulators of angiogenesis, and as well as immune regulation. And specifically, spinal cord neurons are upregulated with certain axonal pathfinding molecules that are typically associated with spinal cord development. Notably, differentiated brain-derived astrocytes are largely involved with the regulation of synaptic function, and specifically brain-derived neurons, which will be of particular highlight for the rest of this presentation, are enriched with a lot of excitatory or glutamatergic receptors themselves. So now that we've evaluated and determined that neuroprogenitors are drastically different intrinsically, we then want to inform whether this then informs therapeutic efficacy and whether this intrinsic factors are then maintained in the transplant environment. So our lab uses a dorsolateral bilateral clip compression of the cervical spinal cord. And so specifically, we injure the C6-7 level. And experimentally, we transplant these cells 2 weeks after injuries, 2 weeks after SCI, allowing the animals to recover. And for a span of 2 months, and at endpoint, what we see is we evaluate functional behavior, and we also evaluate electrophysiology to determine the extent or the maintenance of this intrinsic excitability that we see in a mismatching graft. So primarily what we see with our first evaluation of motor outcomes, so we evaluate grip strength, which is the animal's ability to grip onto a metal wire when we pull back, and we measure gram force. So what we see over a period of time that our regionalized grafts, so derived from the spinal cord, improve physical recovery with grip strength as early as 6 weeks post-transplant. And we don't see statistical significance with our mismatching grafts, though there's a slight trend in increasing their motor abilities. We also are able to evaluate specific parameters involved with the catwalk nodulus gait system. So this measures different gait parameters involving stepping intensity, swing speed, and stride length. And notably what we see is a relative improvement in either animals that receive a cell transplant, but we see a lot more of a consistent step pattern with our regionalized graft. And this is outlined with some examples of these parameters where the animals are moving quicker and they're also have larger strides within their forelimbs. And this is importantly significantly different with our regionalized cell grafts relative to a mismatching graft, as well as our vehicle injury animals. So finally, we want to evaluate the electrophysiological parameters that different grafts impart onto spinal cord injury itself. So important Importantly, SCI requires a balance of excitability and inhibition to impart its function. So primarily what we see when we elicit a response in the motor cortex and we measure the response in the animal triceps, so the ability of these transplanted cells to relay a signal, what we see is that there is a delay in response with injury itself relative to sham, and either cell transplant is importantly able to restore this latency. However, if we look at the level of excitability, which is essentially the amplitude of response within the motor evoked potential, what we see is that injury has the greatest amount of excitability, which cannot be restored by a mismatching graft, but importantly can be restored by a regionalized graft. So we see this normalization of hyperexcitability in SCI that can only be restored with a regionalized graft. So now to reiterate some questions that I posed at the beginning of my experiment. So we want to determine whether NPCs are intrinsically the same. So importantly, they are drastically different, and there is a large regional distinction that's retained in the differentiated cells from these regionalized progenitors, so specifically with neurons and astrocytes. So we want to evaluate then whether these spinal cord NPCs can directly improve motor outcomes. And yes, we do see this with minimal improvements with a mismatched neuroprogenitor. And finally, we want to evaluate whether these intrinsic features are maintained following transplantation. And importantly, they are. So with the mismatching graph, what we see is this maintenance of intrinsic excitability, which already contributes to the maladaptive hyperexcitability that we see in SCI itself. So thus a translation and research claim that this presentation can then make, that being that a therapeutic recovery in motor function thus requires a transplanted, regionalized, and specifically a spinal cord derived neuroprogenitor to balance this maladaptive, excitable spinal cord injury environment. And so finally, I'd just like to end with a couple of translational implications and claims of this work as well. So primarily, we propose a pathophysiological mechanism of maladaptive excitability in spinal cord injury, which can only be normalized with the transplantation of a regionalized progenitor. And largely, this informs clinical manufacturing of more human and clinically relevant induced pluripotent stem cell models derived typically, or it could potentially be from allogenic models, and informs a lot of procedures on how we need to essentially derive cell therapeutics for when we push these iPSC-derived therapeutics into the clinic. And finally, this research also has large implications for other degenerative states within the CNS. So this maintenance of this regional phenotype following transplantation also suggests that we can restore other degenerative or other injury-related conditions within other contexts of the CNS, so within different regions of the brain as well as the spinal cord. So I'd like to acknowledge everyone that's contributed to the work, and thank you everyone for listening to my presentation.
Great job, William. I'm going to invite our favorite person, Dr. James Rutka.
Thanks, William. I really enjoyed your presentation and your work. Because you show that location matters, and you demonstrate the dogma that all NPCs, neuroprogenitor cells, are created equal may not be true. So my questions to you are, if you go a little bit deeper into location, so for example, if you took progenitor cells from the cervical spine region versus thoracic or lumbar, would that make a difference? And maybe specific regions of the brain would also make a difference. What do you think?
Yeah, there's a lot of unique studies that transplant different regions or different progenitors from different regions of the brain, and it shows once again like this relative maintenance in cell phenotype, and it impacts largely the integration. Taking from different areas of the spinal cord, that's the very first thing I did when I first started my grad school degree. And based on our hypothesis, we wanted to evaluate a bit more of a drastically different neuroprogenitor. There's a lot of overlap in expression between a cervical, thoracic, and a lumbar-derived neuroprogenitor cell from the spinal cord, specifically relating to the expression of homeobox genes, which dictates probably the largest amount of expression. But that'd be a very interesting study to look at different areas of injury and whether if you can pinpoint exactly to the region. But I can say there is a relative maintenance of gene expression, even a difference between like a cervical and a lumbar derived NPC.
Okay, and then your RNA-seq data showed essentially bulk information, where in the brain you got one result, an excitotoxic type of NPC, versus the spinal cord, which did not. But I wondered if a technique like spatial transcriptomics could have been used, for example, to find differences that would have informed your study.
Yes. Primarily, the first bit of information I presented was bulk RNA-seq on differentiated progenitors in vitro. Spatial RNA-seq would definitely be ideal. I know other people from our lab have done similar studies that looked at spatial RNA sequencing. I haven't. It would be ideal to do in the best world where all the funding was available. I was fortunate enough to do single nuclear RNA sequencing on the transplanted cells themselves, just within the confines of this presentation couldn't be presented today. And it also shows a maladaptive response with a mismatching environment. So if we have increased excitation or we're transplanting a cell that is increasingly excitable, interestingly what we see, it's reflected in a lot of oligodendrocytes and inhibitory neurons post-transplant. They reflect this high ability to mediate calcium efflux, which is related to increased excitability.
Okay, then finally, do you think now, knowing what you know, you can engineer the perfect NPC yourself to try to dampen down that excitatory response area of the spinal cord injured site? Is that possible?
Yes, so with a lot of extrinsic morphogen gradients that we know can be used in combination to create a spinal cord-like cervical cell during development. That's another thing I did for another experiment I did for another aim of my PhD thesis. So it's essentially a combination of, if you take an iPSC-derived cell, you first have to posteriorize it with Wnt signaling and then induce it with retinoic acid to create this expression of those homeobox genes. And that creates a spinal cord-like phenotype, importantly. So it's very cool.
Yeah, great study, great presentation. Thanks.
Thank you.
Okay. Well, thank you, Catherine, for moderating this session, and thanks to all of the speakers and their supervisors. Amazing research work. So we're going to take a break for the next hour, and there's coffee outside, and the e-posters are upstairs, and it should really be a lot of fun to enjoy. And we will be back in an hour at 10:40 for a very special symposium on robotics and surgical simulation. So we will see you in an hour.